much rather hear that song than me talk to you guys. But Jill, thank you very much for that kind introduction, and to all of you and the trustees of the Bone Cancer Research Trust, a very big thank you for including me in your 7th conference, and I really think it's an absolute pleasure from us as the Irish wing of the BCRT to be here today, and we value any opportunity to discuss and share information and as a team go forward. So thank you very much to you all. The collaboration. I really believe that's what it's all about. And hopefully in the next 19 minutes, I can impart in you a little bit of information about the important role that collaboration plays and needs to play in the future to improve the outcomes in our cohort of patients, our children, our young adolescents, and our adults with bone cancer. I aim to do it in two formal ways. I'm going to first discuss a very personal case, a patient of mine, and it's a rather sad case, but bear with me because there's a very important message from that. And then secondly, to use the example of osteosarcoma as a paradigm, as a role model of collaboration. That's not to say osteosarcoma has much more collaboration than Ewing sarcoma, but just for the sake of time, it's an example to illustrate that point. Donald was 12 years of age when he started complaining of pain just above his right knee. There was no history of trauma, and he didn't know what was happening. Apart from playing sport, he thought it may be a sporting injury, but the pain persisted and got worse. And finally, an image was performed. He was referred to us, and this demonstrates a large tumor sitting at the end of his thigh bone, the right femur. He underwent a biopsy, which confirmed this to be a high-grade osteosarcoma. A metastatic workup looking to see if the tumor had gone anywhere else in his body. Thankfully, didn't show any tumor. And as a result of that, he was started on treatment following the Uramus protocol. He completed 10 cycles, or 10 weeks rather, of chemotherapy, which he tolerated extremely well. And then he underwent his surgical resection of the tumor. And as you can see from this slide, the bottom third of his thigh bone was removed, including the knee joint, and he had an endoprosthesis, or an artificial knee, implanted into that area. The pathologist looks at the tumor under the microscope and confirmed that the chemotherapy had been very successful, with the majority of the tumor being killed by the chemotherapy, with over a 90% kill factor or necrosis factor. With that knowledge, I told Donald and his parents that with him having a localized osteosarcoma and a good response to treatment, he's in the good prognostic group, and hopefully our treatment will be successful in the region of 60 plus, maybe 70%. He went on to complete his treatment, just under 8 months of treatment. He sailed through very well. There was no evidence of any tumor at the end of his treatment, and he was in complete remission, which he remained for at least 3.5 years. And at that stage, my hair was getting grayer and grayer as I was getting older and older, and he was maturing. He was starting to play more sport, get into cycling once again. But about 3.5 years later, he came into our clinic appointment complaining of just a very mild cough, and on 1 or 2 occasions had blood in his cough, in the sputum that he was bringing up. So we did a chest x-ray, and unfortunately there was a shadow in the bottom of his chest x-ray, which to us oncologists is always a real worry, necessitating a CT scan immediately on the same day. And once again, unfortunately, you can see a recurrent tumor in the base of his left lung. That is his heart, as it is a cross-section image of his chest. We sat down with Donald and said, unfortunately, what we were hoping not to happen had happened, that his tumor has come back, that it has metastasized to his lung. But what I needed to do was look to see if there was tumor in any other parts of his body, because that would help us decide what future treatment to plan for. So a bone scan was done, and this is a normal bone scan, which is good, that there was no sign of disease anywhere else, apart from that one lesion in his lung. So we went ahead with a surgical resection, the best form of treatment of a metastatic lesion in his chest. And we managed to get the tumor out, but unfortunately, the tumor was very friable, and there was some rupture of the tumor at the time of surgery. That required us to come in with further chemotherapy after this, and after 4 months, he bounced back extremely well and was well with no evidence of disease again. However, as he was getting into his cycling once again, he unfortunately was hit by a car and he fell, injuring his right shoulder, but unfortunately the shoulder didn't improve over time, the shoulder discomfort, and he came back to me saying the shoulder really is just not quite right. And unfortunately, in that right shoulder joint, you can see a little bit of a moth-eaten appearance of his upper humerus. And as a result of this, unfortunately, we had to diagnose that he had further recurrent bone disease. We did a bone scan, and this time, unfortunately, we not only see it in his right shoulder, but also his left shoulder. And one of our new scans, a nuclear medicine scan, a radioisotope scan, demonstrated further disease in both shoulder joints, as well as in one of his first the head of the left rib. Unfortunately, with chemotherapy being used, and now with disease in multiple parts of his body, there was no known curative treatment for Donald. And after a long discussion, a very honest and emotional discussion with Donald and his parents, we opted not to do any further treatment. And he went home and spent 6 months of exceptionally good quality of life, but with significant palliative care symptom control. And unfortunately, he passed away approximately 6 weeks ago. The reason for me mentioning Donald's case is because I think Donald epitomizes what we as a community, as patients, as parents, and as healthcare providers must not do, and that is rest on our laurels to think we've got this tumor beat. We have a long way to go. We've done excellent work to getting to a 60-70% survival, but we've got to push that boundary further to that 30-40%. We have to bring that down. So we believe we're not good enough yet, and with the help of the BCRT and the whole international community, we've got to improve that. And the only way we can improve that is by collaborating. I'm going to take you back to the 1970s when chemotherapy just came onto the scene. Up to that stage for osteosarcoma, our only real treatment was an amputation and surgical removal of the tumor. With the introduction of chemotherapy, we managed to push the survival from 20 to 50%. And this was one of the first published articles in the mid-80s when patients were randomized to only surgery, plus surgery and chemotherapy. And I just want you to see that the blue line demonstrates a much greater survival when patients got adjuvant chemotherapy as compared to patients who just received an amputation. So therefore, in the 1970s, we knew that chemotherapy together with surgery was better, but we didn't know what chemotherapy combination to use. It was at that stage, this is now into the late 70s, early 80s, when a group of people got together here within the UK and joined forces, combining one group, the MRC, the Medical Research Council, with our then very junior and in its infancy United Kingdom's Children's Study Group, the UKCCSG, and also the soft tissue sarcoma group from the European counterpart, and finally from the International Society of Pediatric Oncology. 4 separate entities got together and said, let's pool our resources to try and get our data and research in a much more statistically significant fashion up and running. And this European osteosarcoma intergroup did stunning work over 2 decades. Between 1983 and 2002, they ran 3 randomized controlled trials in patients with localized osteosarcoma, accruing over 1,000 patients, which is a significant number of patients. The overall survival throughout all of those trials was still in the region of 50 to 60%. But look at this. It took over 20 years to perform these trials and enrolling 1,000 patients. At the end of this, we still didn't really know what was the best chemotherapy regimen to use. As a result of that, collaboration became even more extensive, going internationally and across the pond and transatlantically even, where 4 new groups came together. The original EOI, the European Osteosarcoma Intergroup, together with the Children's Oncology Group, the Cooperative Osteosarcoma Study Group, and the Scandinavian Study Group. They all pooled resources. And with this diagram of the map, you can see that with the Children's Oncology Group, now we're including the North Americans, the Canadians, and the Antipodean countries in the mix. With COS, the Cooperative Osteosarcoma Study Group, these are the German-speaking European countries. The EOI, which we were included in, Belgium, Ireland, Netherlands, and the UK. And then finally, the Scandinavian group joined in too, making the 4th collaborative group. As a result of this collaborative effort of including over 20 countries in the osteosarcoma trial, accruing over 2,000 patients in just 6 years, a stunning paradigm of research in a rare tumor of international collaboration. You're going to have to be a little bit more patient because tomorrow Jeremy Whelan will discuss the preliminary results of this trial. The results are not finalized yet because the data is still to be analyzed, but I can hopefully be optimistic that we're making some inroads into this disease. Importantly, because of the great collaborative effort, this made significant headlines in the scientific international community, because for the first time, a transatlantic international collaboration was organized in a very get up and go beat attitude. And publications, and even in this textbook, this was well set out as the paradigm of how research should be formed now. So where are we now in 2013? We still believe that survival is in the region of 60% plus for patients with localized osteosarcoma. We do not seem to have made significant difference with our chemotherapy over the last 30 years, but hopefully the Euromus results will give us a bit more positive attitude on that one. But even if there is some positive attitude there, I still think we have to work much harder internationally to get more and more research done and more clinical research interaction to help our children with this condition. Now, in 2007, literally 7 years ago, in an attempt to get rid of the national legislation limitations within Europe and also within the European community, this organization called ECHO, the European Cancer Organization, came into being in an attempt to bring together professionals involved in cancer research, both clinically and in a research mechanism. It's trying to bring the 60,000 professionals who work in oncology within the European continent together with the International Society of Pediatric Oncology, SIOP, being the main founder of this. SIOP, the International Society of Pediatric Oncology, is heavily involved in forming a European network for cancer research in children and adolescents. And Ian himself, Ian Lewis, is already part of this organization, and as you can see, it's now gaining in numbers. This organization is helping to feed and guide the parent organization called ECHO in an attempt to help delineate and plan a virtual European Clinical Research Council. The objective of this council is to become a single voice representing the pediatric and adolescent oncology clinical research community across the whole of Europe. And I believe this is the only way forward that we can harmonize all of our research and clinical opportunities within the European continent first, and once we've done that, we can then extend ourselves internationally once again. Hopefully I have given you an indication from a limited collaboration due to national and European limitations. We are moving to the theme of your conference here, and that is limitless collaboration, because that is absolutely crucial. We should have no boundaries to collaborate on such a rare tumor. Extrapolating that to what you're doing here and keeping the voice and being an absolute role model and an advocate for our young patients, together with this proposed limitless collaboration, I believe we can make great headway into improving survival and also making the quality of life of our survivors much better than at present. That's what I aim. All of our patients, hopefully, can come out and hit the tape at the end of the race with a great quality of life, but we can only do it by working together internationally. So thank you to all of you for at least raising the flag and for advocating on all of our patients' behalf. Thank you very much.
Questions? Questions?
I noticed in your map that only Guatemala is in that group. What is happening with the rest of Central and South America?
A great question. The Children's Oncology Group is predominantly a North American organization, but over the last few years, more and more countries are becoming involved. So Switzerland is part of the Children's Oncology Group. Mexico is now part of the Children's Oncology Group. And therefore the thrust is coming from to go outside of the developed countries into much more of developing countries, but that process is slow. I believe we should be one global collaborative organization. That is our aim, and hopefully we can get there. Not yet. That's what we have to do.
Are there any other questions? Perhaps you join with me in thanking our speakers.